Her name is Destiny. She is 19 years old and she lives in Southeast DC with her grandmother and little brother, who is 10. 6 months ago, her mother went to the doctor for a cough that would not go away. Her mother didn't smoke, not one cigarette. The doctor said it was probably allergies, then a cold, then stress. 11 months and 3 different providers later, her mother was diagnosed with stage 4 lung cancer. Destiny's mother passed away 4 months after that diagnosis. Destiny has not cried in front of her little brother once. She thinks she stays strong, then he will be okay. She thinks grief is something you push through. Nobody has ever told her anything different, and nobody has asked her how she's doing. Today's guest has lived through this story from 2 sides, as a mother and as a nurse practitioner who has spent over 20 years watching children carry grief that no one ever helped them put down. By the end of today's episode, you're going to understand why lung cancer is not just a smoker's disease. You're going to know the signs that get missed and why. And you're going to learn what actually happens to children when loss goes unaddressed and what we can do about it right now. This one is for Julian. And it is for every family sitting in a waiting room who deserves better. If someone in your life has a cough that will not quit, this episode is for you. If your family has been told not to worry, this episode is for you too. And if you're a child, a teenager, a parent, a nurse practitioner, or someone building a healthcare business in a community that has been underserved for far too long, I want you to stay right here. My guest today is Jean Fletcher. She's a master's prepared nurse practitioner certified in both psychiatric mental health and pediatrics. She has practiced for over 20 years. She works with the youth in Washington, D.C. and Prince George's County, Maryland. She volunteers with grief organizations that serve bereaved children. She's building a practice and a foundation in honor of her son, Julian, who is 27 years old, did not smoke, and was diagnosed with lung cancer in May of 2019. His provider called it a zebra. That means that they did not believe it was possible. Julian passed away December 28, 2020, 19 months after his diagnosis. Jean is here because she turned that loss into a mission. Jean, we thank you for being here. Before we get into everything, I want you to talk directly to the person who's listening or watching right now. What will change in their life if they really take this conversation to heart?
If what they would take away is, one, how important it is to advocate for yourself and for your loved one. And two, to understand that no matter how bad things look, there's always hope. There's always hope, and we can all learn from this story right here.
Absolutely. If you're new here, welcome to the Melanin Initiative. I'm Dr. Kimberly Madison, a doctorally prepared nurse practitioner, and one of your co-hosts here at the Melanin Initiative Podcast, along with Alicia and Geraldine, who send their love in their absence. We're a health literacy podcast. When we say health literacy, we're talking about your ability to obtain information, to understand that information, and then to use it to manage your health and advocate for others. Here, we break down complex medical information into information you can understand, and we do it with 2 missions. One is to promote that health literacy, to break down this information into a way that a 5th grader can talk about it. 2 is to elevate the expertise of nurses, like we're going to do here today with Jean, to bring awareness to all the diverse career opportunities in the healthcare industry besides being a nurse and a doctor, and all the ways that our peers, nurses, doctors, therapists, psychiatrists, PT, OT, pharmacists, can leverage our expertise, not only caring for patients, but also as entrepreneurs. Remember, this show is for educational purposes only. The opinions expressed here are opinions alone. They are not a representation of any of our affiliations. If you think you might be experiencing a medical emergency, you seek medical attention and medical guidance from your healthcare provider. If you or someone you know might be having a physical emergency, heart attack, abdominal pain, a headache, you can call 911. If you or someone you know might be having a mental health emergency, anxiety, depression, paranoia, then you can call 988 or text 741-741. And this is your chance to participate in the show. Give us a thumbs up, leave a comment or 2, follow us on Spotify and Apple, and share this show with at least one person. Now, before we get into everything today, and I thank Jean because we haven't talked about lung cancer yet. So this is a big deal. This is a big episode for us. We want to get to know her a little bit on the personal side. Something that's a little bit hard for clinicians to do is to take off that hat and talk to us about what it means to be a person. So we're going to spend 5 minutes doing the Ikigai questions. This is a Japanese idea for finding your life's purpose. If she answers her questions, I invite you to do the same for yourself. Whether you're about to graduate high school or you're about to enter your third career, at any point in time, you can rediscover your life's true purpose. These questions and your life's purpose live at the crossing of four things: what you love, what you're good at, what the world needs, and what keeps you going. Okay, so let's get into it. So, Jean, what excites you most about the work that you do?
I love to see when I'm working with my teens, I love to see them feel safe. And, initially they always come guarded. And by the end of our visit, they let that guard down. And I love to be able to see them become themselves and be able to relax.
And what about when you're at home and you're not working and there's no patients in the room?
What, oh, what do I love?
Yeah, what excites you?
My garden excites me. Just my home environment, it excites me. I love creating and trying to figure out what else to do. I have plants, and so I love to have plants that always, just watching them peak and bloom it just makes me feel really good.
How do you have time to have a garden, Jean?
You know what? It's Julian's garden, and that gave me time. I used to be a person who never liked putting my hands in dirt or even doing anything with a garden, but I had this vision of creating something for Julian, and that was very easy to do. I just saw it in my mind, and I was able to create it by the help of others, of course.
Okay, I like that. What comes naturally to you that others seem to find hard?
I think I said this last time, but it's definitely listening. I tend to listen. I can listen very well to others. I'd rather listen than talk.
Again, one of our greatest clinical skills, both as a clinician and as an entrepreneur. And I love that you have answered these questions before. When you look back at all your episodes, you'll be able to see your own journey and see if that changes at all. If you recognize Jean, she's the guest star of our newest series, Becoming a Nurse Practitioner Entrepreneur. She's one of the participants in Duke's University's Nurse Practitioner Entrepreneurship Program. And she has already filmed, and you can already watch her first episode. All year long, she'll be joining us, taking us through that journey. And so she's back to share her expertise in a different way. What problem do you solve, not at work, but at home and in the community? And what does the world need from you specifically?
The problem that I'm working on right now is grief.
Mm.
I find that grief is a universal experience, but a lot of people do not want to address it. They rather avoid it, ignore it, suppress it, do whatever they can. And it's unfortunate because I believe we are a grief illiterate society.
And that's why this episode is so important. So, we led with lung cancer, but we'll also be covering pediatric palliative care, unresolved grief, not only in the patient, but also in the care providers, both professional and friends and family. And of course, we're always going to talk about what you can do about it. We're not just here to talk about the problems.
Yes.
Okay, so and without talking about your title, all your degrees, all the roles that you play, who are you, Jean?
I am a sensitive, loving person. I am fun. I can have a lot of fun. And certainly I'm a child of God. I'm a believer. I believe in Jesus. So I'm a Christian. Mm, that's
Yeah, that's enough. There's no perfect answer,
yeah.
right? And then maybe it gets easier every time you answer it.
Yes.
So that's your ikigai. That is exactly why you're here. Now we want to hear how you got there. You're gonna take us back to the beginning. Tell us your story, not your resume, your story, who you were before all this, and what has this journey actually looked like.
I am one of 5 kids. I grew up in Philadelphia to 2 wonderful parents, Maurice and Ann Chapman. And, I had a lovely childhood. I was blessed. A strict parents, of course, and, went off to college, went to Hampton University, and I love my home by the sea, and I became a nurse, and it's truly my life. It's my, it's my ministry. So,
Okay, and so take us to the part of your life where Julian enters your story.
okay, so I married my college sweetheart, Marvelous Marvell, and we had 2 children. Julian was our firstborn. He was born May 31st, 1993, and then my baby girl was born 2 years later, and, I can say I just was a blessed woman, I always wanted to have children, and I was blessed to have both Julian and Marissa, and, they were both healthy healthy children, and, they grew up healthy, so it was a, you know, perfect it was just perfect for me.
Mhm. So I do want to make some space for you. I love to say nurses are patients too. So the topic, just, having the topic itself is a sensitive moment. So at any point in time that you need some time, you just take that time. You don't have to apologize. Okay.
Yeah,
It's actually a beautiful example to our audience on how grief shows up, how we continue to live with that. The other thing, you just came from a whole morning of training other people about grief. So your heart is already pretty full. And you just told me that Julian's birthday is coming up.
yes.
So I know that when we have those anniversaries coming up, it's a sensitive time, and Mother's Day just passed too.
Yeah, thank you for acknowledging that. And that's one thing I did mention this morning, how May has been difficult in some ways. In other ways, it's just been a wonderful thing to be able to reflect and enjoy. May had always been a great time for us in terms of celebrating Mother's Day and celebrating Julian's birthday, and it's my anniversary. My husband and I got married in May, so we'll be celebrating 35 years of marriage this month as well. So May has always been, really good to us. And Julian is smiling down on us. I know I can tell you on Mother's Day, I couldn't believe it, but a cardinal landed in our garden on Mother's Day. And it's not the first time he has shown up in very special ways. So I was very appreciative of that.
Mm. Thank you for sharing that. And thank you for still being here and showing up to do this episode. Okay.
This is so important, and I thank you for giving me this opportunity, Kim. Thank you.
It's our pleasure. So talk to us about when I guess he started sharing with you that he was having symptoms.
It was it was December. It was like right around Christmas time of December 2018, and he had a cough. And so we really thought he was just catching a cold at that time. So it was right about Christmas time, and I remember being at our, mother-in-law's, and my mother-in-law and father-in-law prayed over Julian because of his cough,
Mm,
and it was pretty significant because it was a powerful moment that they prayed over him, and Julian was laying down at the time and just had this cough that wouldn't go away at the moment, but it was the first time we noticed it was Christmas, and that was 2018.
okay. All right. So let's get into our main topic here. So I want you to start where Julian's story starts. His provider looked at a 27-year-old who didn't smoke and said it was a zebra, that it's not possible. So let's talk about what the research actually says, because Destiny's mother also did not smoke. And I want every person listening to understand that this actually is not as rare as you might think. This is happening. Is that right?
That's correct.
Can you see this in your own practice?
I haven't seen it in my own practice, no. I've worked with adolescents pretty much, so no, I haven't seen it in my own practice, but from what I understand, like 20% of those that are diagnosed are younger people.
Mm.
That's
So
a
from that
great number.
From the time that December when you saw him and everyone started to really pay attention to the cough, what happened after that?
Well, first, I want to make a quick correction because I made the mistake and said he was diagnosed in May of 2019, but it was actually March of 2019.
Okay.
And so what happened was after Christmas passed, he almost seemed like he got a little bit better, but then the cough continued to linger throughout the month of January, and he had a little runny nose. So at the time, we had just got our carpets pulled. So initially, we were like, wow, you had a cold, now you have allergies. It's probably from the carpets that were just pulled up.
Mhm.
And so at the time, we were he was self-medicating himself with, like, cold medicine, and I recommended some allergy medication just to see if maybe that's what happened. And then by February, I wanna say it was February, was when he first encountered the doctor. I finally told him, "Call your primary care, make an appointment." And he did. He was initially diagnosed with, like, bronchitis,
Mm.
and told to go home. He should be okay, not too much to be concerned about. Um, he was told to return if he didn't get better. His cough continued to be the same, and it didn't necessarily get worse, but he continued to have a cough, and at this point, you know, he went back, and I said, "Julian, ask for, a PPD done or screening for tuberculosis because your cough has been going on for about 6 weeks now."
Mm.
And, he told me that his doctor didn't think he was at risk for that, so he didn't need that test done, and I actually said, "Yes, you do." So, my son actually called his doctor and went back. He got tested for TB, and was told that was negative, and at this point, because he still had the cough, the doctor did prescribe an antibiotic for him and told him if he didn't feel any better to, get it, returned. And so a week later, my son actually was getting worse, so he went back, and this time his doctor gave him another antibiotic. And honestly, I was just like, "What is this? Why isn't he getting a chest X-ray at
I
least?"
was just about to ask you, when does that come into the picture?
I was just like, "Did he do this? Did he do that?" And I think at this point, my husband went to the doctors with my son,
Mm.
and my husband was like, "No, no, Gene, he didn't do that." And I'm like I was getting frustrated. I'm like, "A cough that's been going on for 6 weeks, I have to ask for a TB test. He didn't do a chest X-ray. What is going on?" So, I remember going to work and discussing it with, one of my medical doctors that I worked with, and he thought, "This is unusual." He said, you know, um, "This may be." He was throwing things out there and said, "If he doesn't get any better, I would just take him, to get looked at by another provider." And I said I would do that. And of course, what happened was that very evening, my son coughed so hard that he had blood in his cough, in his sputum, and that just really alarmed me, and I said, "Nope, we're going to the urgent care." So I took him and he got an X-ray, and at that point, the X-ray showed what they thought was pneumonia, and they started him on a stronger antibiotic. So now this is round 3 of antibiotics. And I remember talking to the provider again and telling him, and he said, "If the antibiotic doesn't work in 24 hours, Gene, I would take him to an ER." And I definitely said I would do that. And I remember thinking, I looked at the X-ray myself, and it was a middle lobe pneumonia. And I thought, that is very unusual to have a middle lobe pneumonia. I said, something is really wrong. And, as healthcare providers, we can't help but think things. And I remember I didn't think cancer. That's the one thing I didn't think. So anyway, I was just concerned that this was unusual. So that was Friday. Sunday, we were getting ready for church, and I went to check on my son, and he was standing up, but he was leaning against a wall, and you could tell he was having difficulty breathing, and he was trying to get dressed. And I said, "Oh no, we're going to the ER now," because I didn't see my son in that condition prior to this. Before it was just a cough. And we got to the ER. They took him right away and they did a CAT scan. And when they completed the CAT scan, they said, "Yeah, your son has a fungal pneumonia." I don't know how they determined it was fungus, but the way it looked, they said it appeared that it was a fungus. And I said, that's very strange because he's not immunocompromised and he doesn't work in farmland. So at that point, I'm very concerned. And they said, "You need to follow up with your primary." Well, I said, "We're not following up with no primary care doctor at all." And by the grace of God, I knew some people who worked at Washington Hospital Center. My dear friend Sharon and my friend Vaughn, they both worked at, well, Sharon worked at Hospital Center. I called her. I called Vaughn, who told me to give my friend Sharon a call. And she worked in pulmonary, and she got us in the very next day. And that was a blessing. I cannot thank God enough for our network. And they took him and did a big workup on my son. Lots of blood work, other tests were done. And they basically said, if all the blood work come back normal, we'll go ahead and schedule for a bronchoscopy. And by the end of the week, because we went in on a Monday, by the end of the week, all his blood work had come back perfectly normal. So they had scheduled him for a bronchoscopy that now it's March. So the following week. And it was supposed to be on a Wednesday, but my son called me on a Monday prior to the bronch that was going to be done. And he said, "Mom, I'm coughing so bad. Can we get this bronchoscopy done sooner?" And I called the office and they agreed. So they did it that Tuesday, which was March 12th. And we got to Washington Hospital Center and excuse me. We got to Washington Hospital Center and the providers were tremendous and they explained how the bronchoscopy was going to go. And they said by the end of the bronchoscopy, we should have an answer to what's going on with your son. Um, they had they had somebody on site that could go ahead and read the biopsy results right then and there. And so I remember, they took Julian back, that this would be about 45 minutes. And I remember running to go get a cup of coffee and meet a friend who we were at Hospital Center, and I have friends that work at Children's. And a dear friend of mine met me and she prayed with me. And by the time I came back upstairs to the waiting room, they came out and they asked my husband to come on back to where Julian was. Whew,
You're doing great, Jean. You're doing great. Take your time.
thank you.
Yeah, you're doing a beautiful job.
They took us back and it was a room full of staff. It was nurses, doctors, it was the pulmonologist, and they basically said, and poor Julian, he had the mask on from they had oxygen for him because the procedure was it was very traumatic for him, and it caused a lot of coughing, and it caused him to have tears in his eyes, and just from all the coughing, and they were like, Julian has stage 3B lung cancer. And we were like, pardon me? And they were like, yes, he has stage 3B lung cancer. And I said, primary? Because I've never heard of a 25-year-old being diagnosed with lung cancer. And they were like, yes, it's primary lung cancer. And they stated that it was adenocarcinoma. And I just said, how is this even possible? And they were like, your son is young, he is healthy. There have been so many great advances in lung cancer. He's going to do well. And I thanked them. I said, okay. So I felt very encouraged. I felt very confused, very disoriented. I looked over, there was a nurse crying. It was a very emotional moment. It was unbelievable. It was a very unbelievable experience, and I still can't explain to you to this day how I stood standing. Because the whole time I just imagined falling out or passing out, but He gave me the strength to continue to be aware and alert and able to stand. So after they informed us, they took Julian to the recovery room, and we were able to meet with him once they got him settled. And my friend Sharan, she met me over there, and she just kind of gave us the support that we needed. And the whole time, they were just getting Julian situated. I imagine they were going to admit Julian into the hospital to get started with treatment. So when they told us they were going to send him home, I thought, pardon me, you're sending him home? He needs treatment. He has lung cancer. And they were like, yes, you're going to follow up with the oncologist on Thursday because it's Tuesday. And I said, he needs help. He has lung cancer. And they were like, yes, he's going to go home and recover from the bronchoscopy, and then you'll bring him back on Thursday. And I said, okay. So they provided all the paperwork that we needed. My husband went to get the car. The nurses got my son in a wheelchair. They prepared the paperwork and everything. And then something unbelievably happened. All the nurses and the staff in this recovery center gathered around Julian, and they just poured into him. They told Julian he was going to be okay, that they were praying for him. I mean, my son was crying, I was crying, the staff was crying, and I've been in nursing for a long time, and I just couldn't believe that powerful moment that we shared. I couldn't believe how many people were rooting for my son and pouring into him and praying for him. And they said he was going to be fine. And that meant the world to my son. It just really gave him the strength that he needed, because he actually thought my life is over. Mm-hmm. So it was a powerful moment. And I will always thank Washington Hospital Center for that moment. And I would thank the recovery center that did his bronchoscopy for that moment, because it was so organic. It just happened, and I'm very grateful for that moment.
If you smoke and you want to quit, first we want you to know that quitting nicotine is one of the hardest things a person can do. Not because you lack willpower, because nicotine physically rewires the brain. This is not a character issue, this is a chemistry issue, and you do not have to do it alone. Here are your options: nicotine replacement therapy, patches, gum, lozenges, and inhalers reduces withdrawal symptoms by giving your body a lower, controlled dose of nicotine while you break the habit. They are available over the counter. Chantix is a prescription medication that reduces cravings and makes smoking less satisfying. It is one of the most effective cessation medications available. Bupropion is another prescription option that reduces cravings and is especially helpful for people who also experience depression. Counseling and behavioral support, whether in person, by phone, or through an app, significantly improve quit success rates when combined with medication. Call 1-800-QUIT NOW for free telephone counseling. Visit smokefree.gov for free apps and text support. And talk to your care team about which option is right for you. Quitting is possible, support is available, and you deserve both. This message is brought to you by the Melanin Initiative Podcast, where we simplify health information so you can advocate for yourself and for the people you love. Find us on Apple and Spotify.
Thank you for that. I want to back up a little bit to make, because we're a health literacy podcast, to make sure everyone's following along. So first thing I want to point out is blood. When you cough and you see blood, that's not normal. We always want you to get checked out. Now, if you're telling me I've coughed and I've had blood for over a decade, so you've already gotten answers, you've already gotten a diagnosis, you already know why it's happening. If this is happening to you for the first time, I want you to go see somebody who can give you answers. Blood in your cough, in your urine, in your stool, it's not normal if you have not been given a reason why. What did you say when you went to urgent care that made them take him back right away?
I said that my son has had a cough for over 6 weeks. He's been dismissed. He's been on antibiotics. He's short of breath, and he is, he barely could get dressed today. I'm really concerned about him.
Okay.
And then they did his weight. This is something that really struck me. They weighed him. My son had lost 20 pounds.
Okay.
Then I knew something would be wrong.
And in our training and in our screening, that's one of the things we look for, right? Weight loss without trying. And 20 is such an average, that is such a common number to see, right? When we look at the chart, it's always 20.
Yes.
Maybe because the other ones we think, oh, good, I've been cutting back, I've been made, but 20 is kind of like, I haven't really done anything for that to happen. Maybe, and usually by then people notice it. So maybe they're also pointing it out. But I know I've seen 20 in the chart a lot of times. So that's a key indicator for our audience who's watching. And then you mentioned it multiple times. What is a bronchoscopy?
A bronchoscopy is when they actually put a tube down into your throat, into the bronchioles of your lungs to examine the lungs and to actually they did a biopsy at the same time. So they were able to get a couple samples from different areas of my son's lungs.
Wonderful.
So it's pretty invasive, and it was, as my son he called it traumatic because he put this fold, like a blindfold over his eyes so he couldn't fight or see what was actually happening. And they insert a tube down into your the trachea, into the bronchioles.
And there's a little camera, and they're looking at a big screen next to them to guide what they're doing, where they're going. And the first thing everyone wants to say, is it going to hurt? Are they going to put me to sleep? That's all that people care about.
That's it. And no, they did not put my son to sleep.
But they gave him some medicine, right?
Yeah, they did. They did give him something to help.
Okay. Yeah.
To relax.
So I did look at some research. So I want to share with the audience some of the numbers, and it's going to reflect what you experienced. So I looked at a narrative review published in Medical Science Monitor just in 2024. I looked at multiple studies and guidelines. A narrative review means that experts gathered and summarized the best current knowledge on a topic. And the reason I even go into that detail about where they come from is because we know in communities of color, we have historically, there's a lack of trust. Yes. And so that's why we don't go early. We don't go enough, and we don't listen to what people are telling us, right? And so just like the textbooks we read, the conferences we go to, the journals that we use to guide our medical decision-making, I want you to know where those are located so you can go and look them up too. Many a times I see a patient, I'll tell them my assessment, my diagnosis, my treatment recommendations. And when I even feel that no one's ever told me that before. I never heard that before. What is that? I say, you know what? I want you to take the next week and you go do your own research. You do not have to trust anything I'm saying. You can go look it up for yourself. And then when I come back and see you, we can talk about what you think and what your decision is,
Yes.
As long as it's not an emergency, we might not have a week, but in most cases, they have the time to go research, go talk to their family. Everyone can sit at the table and make a decision where everyone feels comfortable. Or what I love, coming back with more questions so we can have an even deeper conversation. I love when that happens.
Yes.
And so, and there's different types of studies, and they're not all created equal either. And so that's why I talk about what kind of study it is. And for our nurses, we want you to be involved in this research. So you need to know all the types of research you can be involved in. And actually patients, they bring research to us all the time, and we're so busy taking care of patients, we don't have time to always stay as up to date as they do. A conference once a year for a 3-day weekend, that's not all. You're not always going to be up to date.
That's right.
Now we do have resources that we can look at on a daily basis, but we have 100 patients to do that for. Sometimes you have one patient to do that for, if that's you or your loved one. So your information, your input is very valuable. And so is ours when we come back and tell you that what you got off TikTok, or this research that's 20 years old, or that it was, funded by pharma. Let's talk about how we're going to look at the results, because you can find data to support any point. Every point has research to support it. Okay.
Yes.
So this was a narrative review. They gathered a bunch of information, and what they found is that lung cancer in people who never smoked is actually the 5th leading cause of cancer deaths in the world, not just in America. Now, another one published in JAMA 2025, they looked at 62 different studies that confirmed it. Between 15 and 20 out of every 100 lung cancers happen in people who never smoked. That means if you're sitting in a lung cancer waiting room right now, look around. Statistically, 2 or 3 people in that room never touched a cigarette. What do you think about that?
It's shocking.
Mm-hmm.
It's shocking. And that's the thing that I discovered, because I didn't understand how this was happening to my son.
Yeah.
And they say the average age of a lung cancer diagnosis is 70 years old. And here my son was 25.
And we're taught that in school too, right? So even all of our surveillance and education and screening, we're missing Julian every single time. That's why that doctor told you he was a zebra, something that you don't see often.
That's right.
Yeah. Okay, so let's look at another one. This one's really important for our community particularly. This is a cohort study published in the Journal of Thoracic. That means the lungs, anything within the chest area, and cardiovascular, that's your heart. Surgery in 2024 followed over 2,000 lung cancer patients. Now, cohort study means researchers followed a group of people over time to watch how their health changed. Now, so that means it's not just a one time you come in, do a survey, we take your blood. This is over a period of time. What happens between January and December, or 2020 to 2025. And we get more information that way. What they found was only 50 out of 100 Black women with lung cancer met the rules to qualify for a screening scan. This was compared to 75 out of 100 white women. Now, Black women had 66% lower odds of qualifying for screening than white women. 66. Destiny's mother could have been one of those women who was never even told a scan was an option. And we know that you just gave us another example of that too.
Yeah.
So let's look at the risk factors for someone who has never smoked. Risk factors mean what is it about you that determines your chances or likelihood that something could happen. Not a guarantee, but just your chances. So your family history, your air quality, secondhand smoke, radon, and chronic lung conditions. Now, another narrative review published in the Journal of Thoracic Oncology. Oncology is the medical term we use when we talk about cancer. In 2023, this is just 3 years ago from the time that we're recording, looked at least 6 meta-analysis. It found that a small increase in fine particulate air pollution raises lung cancer risk by 7 to 16%. That's about 20%. And this review made it clear air pollution and the burden of lung cancer falls hardest on Black communities and low-income neighborhoods. We hear this all the time. This is not and it's not a personal failure. It has nothing to do with you. It's where your zip code. This is structural. Now, a case control study published in Nature Communications in 2025 compared over 3,000 people with lung cancer to over 33,000 people without it. And a case control compares people with the disease to similar people without it to find out what might have caused it. And what they found out is people who never smoked but had long-term lung swelling like COPD are 3 times more likely to get lung cancer. And we know with COPD, most patients have had a history of smoking, but not everyone. Not everyone. Even me, as someone with asthma, they even tested me because when I had I also bypassed primary care and I went straight to pulmonary because I just wanted better solutions for my exercise-induced asthma. And so she did x-rays and she saw a bunch of little scattered nodules. And so she had asked me, had I ever been really sick? And I said, no, I never have. And she's like, well, they look chronic, so we'll just monitor them over time.
Okay.
And I ended up doing like I think it was a swab from my mouth, and I mailed that in, and they were checking to see other genes and mutations that I might have had that could explain this presentation on my x-ray.
Mm-hmm.
So for our nurses and our nurse practitioners, a cohort study in Curious in 2022 looked at over 700 lung cancer patients and found that 70% of non-smokers had a specific gene change called EGFR mutation. That matters because there are pills that work specifically for that mutation. Non-smokers with lung cancer should ask for gene testing. That one test changes which treatment they receive. And for healthcare entrepreneurs, this is the conversation that belongs in your intake. A comprehensive lung cancer risk visit, air quality, family history, chronic condition flagging, and screening referral. This is a billable wellness service. A lot of NP entrepreneurs are, if they're not going into wellness completely, they're adding it as part of their service. And the public is demanding more wellness as opposed to just the sick care model. The sick care model oftentimes are pills and surgeries that turn down your symptoms. They're not a cure, and they don't remove them. And we don't really always address the cause. We just turn it down. I like to call it like you have a TV show on and you use the volume to turn it down, but the people are still talking, right? Or we turn it up depending on what your problem is, right? But the show is still on. The show's still going. Whereas in wellness and integrative medicine, we're looking at the whole picture and we're trying to figure out how can we just turn off the show completely, right? How can we get to your problem and get rid of it? So that's kind of the difference. And you have seen us talk about functional medicine, integrative medicine, and you're going to keep hearing us talk about it because there's a demand in the consumer. We see more of our clinicians. Especially those of us who continue to practice longer, get a little bit burdened by the sick care model when we don't see people getting better. And as nurses, that's our training, is holistic care. And so in the way the Western medical model is set up, we don't really get to practice that to the degree that we've been trained and educated. And so you see nurses move into that direction, particularly when they go into business for themselves, because now they can use the whole all of our education and training, all of those modalities, and really work to the fullest scope of our practice. There's actually a book. I just met a lady, she's right there in DMV with you, who is one of the authors of a book called Integrative Nursing. And apparently it's the second edition. I didn't even know that book existed. So she'll be on the show to talk more about it. But you're just going to continue to hear more about it.
Right. Yeah. Very interested in integrative care. And I'm definitely a holistic person. So I believe whole body, body, mind, and spirit.
And money, right? Because I tell my patients, hey, we would not be talking if I wasn't getting paid. And it costs you money to get to the answer.
Yes.
Right. And in the cases, particularly in communities of color, where it takes, 7's another average number. It took me 7 years to get an actual diagnosis. I went through 7 providers before I got a diagnosis. That costs money. It costs money out of your pocket, copay, time away from work. So this is also a conversation about money. And while we can be as educated as we want and we can make recommendations, when you show up to the pharmacy or you go to put your bill in, insurance isn't making the final decision. So it's about the money. We have to talk about the money. Right? And in particular, since we are talking about the difference between conventional and integrative medicine, when you do the conventional model, it's dictated. You get 15 minutes with me, maybe 20. And then that person who's caring for you might get $22 from that whole visit, everything that they've done for you, all the research that they've done, all the questions they've answered. That surgeon who has already completed the surgery might not get anywhere close to what that surgery is actually valued at. Whereas the integrative model, which typically insurance isn't going to cover because insurance doesn't want you to get better. They need a reoccurring customer. That integrative or wellness practice typically can see you for 30 or 60 minutes. It is going to come out of your pocket, but there's no surprise billing. There's no extra fee that's going to come to your door. They can talk to you and figure out a price that works for both of you. And you're going to actually get to the answer, which is what most people are looking for. They want an answer, especially after 7 years, 7 providers, they want an answer to the problem that they're living with every single day. So in this study, they showed those answers. If you're an entrepreneur, this is a billable wellness service, which means you can bill for it, you can get paid. It does not require oncology training. It requires you asking the right questions. The research gives you the questions. You provide the access for your community. In communities where that conversation is not happening anywhere else, your practice can be where it starts. Now, our first takeaway Lung cancer in non-smokers is the 5th leading cause of cancer death in the world. Between 15 and 20 out of every 100 lung cancers happen in people who have never smoked. Black women have a 66% chance of not qualifying, not being told that they qualify for the screening when we compare them to white women. If you've never smoked and you have a family history, chronic lung issues, COPD, asthma, or you live near heavy traffic or an industry, ask your provider about your lung cancer risk today. And if you're building a practice, a lung cancer screening visit is a service your community needs and cannot always find. And we're putting up a screenshot right now. And on that screenshot, it shows you lung cancer risk factors for non-smokers. If you're listening on Apple or Spotify, come on over to YouTube or LinkedIn, take a picture and send it to one person that you know. Now, Jean, Julian's provider called his cancer a zebra. That word has stayed with me since you told me the first time. And what it means is that when a provider looks at a young Black man who doesn't smoke and decides the most likely answer is anything but cancer, what do you think about that?
It angered me. It made me so angry. I just couldn't understand what I felt was narrow-mindedness.
Mm.
And I felt like my son was really dismissed of his symptoms. And I've always wondered, like, what would have happened if I wasn't a healthcare provider? I really wondered what would have happened because my son he's a young male, so no, he did not go to the doctors that often. I had to encourage him to go get checked out. And it just made me wonder how many people are going to their providers and being dismissed of their symptoms. It just really was upsetting.
Yeah, and since the time of the pandemic, now we have COVID in the picture. I looked at a qualitative study published in the International Journal of Surgery case reports in 2023. This is where we followed just one patient, and there they had lung spots that kept being labeled as COVID, completely negative COVID tests. The spots were cancer. And now a qualitative study, they used a deep personal stories, just like Julian, rather than the numbers in one case, in one patient's full clinical journey. That's what we're doing today, showing you his full journey. And the action is direct. If you have a lasting cough that providers keep blaming on COVID or allergies, right? That was Julian's case, and doesn't go away, ask them to check for lung cancer. I always tell my patients, I'd rather go through all this and it be no at the end than not try and regret that.
That's correct. And the other thing they wanted to say is he had asthma, which my son never had asthma before. Only when he was about 2 years old, I think we were up in Maine and there was a forest fire out of Canada. And he had an incident where he required some medication to help with his breathing. And that was the one and only time he had respiratory issues. And it was related to a forest fire. So it was very upsetting the way he was viewed.
Now, I like that you brought that up because one of the studies looked at how this impacts the patient themselves, right? So there's actually a lot of Black lung cancer patients carry a certain stigma of shame, more blame, more depression than white patients with the same disease. And most of the time they're carrying it without any support. I know I didn't get any education on even thinking about that when it comes to our lung cancer patients.
Yeah.
And some of that's probably our fault because of this, how we talk about smoking all the time.
It definitely is a stigma, and I think that bothered my son as well. And I think the Go-To Foundation, which is a lung cancer organization, they were tremendous because they have so much on breaking the stigma, and they have a slogan: anyone with lungs can get lung cancer. So it was an eye-opening experience.
Yeah, we're shedding a lot more light on that today. So let's talk to our nurses and our nurse practitioners. We looked at a cohort study published in JAMA in 2022 that followed over 1,000 adults. So these are good numbers for our colleagues who are looking for confidence to say something back to their patient, to make a decision. These big numbers make us feel a lot more confident. So they looked at over 1,000 adults through a lung cancer screening program. And what they found was just 15% of a gap in screening completion rates between different groups. 21% of Chinese women and 23% of Filipino women had a screening order placed. A nurse navigator, now this is someone whose job is to help patients move through the system. Everybody needs one of those.
Yes.
Significantly change those outcomes. If you're in a clinical practice and you see patients at risk for lung cancer, building a navigator workflow into your intake is a direct clinical intervention. It doesn't require a new hire, it just requires a process that a nurse can build. And next time you go for your performance review, you can talk about how you included this intervention, collect the data, show how it improved outcomes. And when you ask for higher pay, now you have the numbers to back it up. Now, for healthcare entrepreneurs, let's talk about this specifically. Now, this 11-point stigma gap that we just talked about, that's not just a statistic. It's a clinical gap that no one is filling in most communities. A shame-informed, culturally grounded oncology navigation and mental health co-management service where you partner with a therapist or a psychiatric mental health nurse practitioner like Jean is a practice differentiator that does not exist in most places. You do not have to be an oncologist to build this. You just need a referral network, a trauma-informed intake, and the willingness to ask your patients questions that their other providers aren't asking. That combination is billable. A comprehensive cancer support visit with a mental health co-management team can be structured as a self-pay package starting anywhere from $250 to $350 per visit. The market for it is every Black family sitting in a waiting room carrying shame that they were never given permission to put down. And you can incorporate the what we're going to talk about soon, some pediatric palliative care. You can incorporate as many things as you want and layer this on into your practice. What kind of partnership between a nurse practitioner and mental health provider would have meant the difference for you guys?
Now I will say that because we stayed at Washington Hospital Center to get treated, and that was a conscious decision. We looked at other providers. I actually called NIH trying to get my son over to NIH to be treated, and unfortunately, within 2 weeks of his diagnosis, he went from stage 3B to stage 4 because his cancer had already metastasized to his brain, into his bones. And so they automatically got us connected to palliative care. And we had a social worker, a case manager, and I say we, but my son, and I'm part of his care team. So it was us. And then, like you mentioned, the nurse navigator, which she was tremendous. She basically kept everybody together and on page so that my son could get the best care he needed.
Yeah, you need that. We're all working in our own lanes. We need someone who plays in the middle.
Yes.
It's 100, like you need it. Not only do I need it as a provider, you need it as a patient, someone who's keeping track of everything. Now, this is an opportunity for 2 more vocabulary words. You mentioned primary earlier, and now you're talking about metastasis. Can you just tell us the difference and why that came up?
Yes. So primary cancer, lung cancer, is the initial or the original site where the cancer started. And they were able to determine that Julian's cancer started in his lungs. And metastasis is when the cancer has spread to other parts of the body. And so initially when they did his, test, his bronchoscopy and did the biopsy, they could tell that the cancer originated in his lungs. And by the time they did other tests, including a PET scan and CAT scan, they determined that his cancer has spread to other parts of his body, and that included his brain as well as his bones.
And so why we always encourage people to get screened soon, which is quick, is because if we can catch it when it's in the original location, it's a lot easier to manage. It's, like spilling something on your table versus it spilling onto the floor. That's kind of essentially what we're talking about, especially when you talk about getting into the blood or the bone where it's all over, that it just becomes so much harder, not only for us to treat, but for the person to experience, right? And then, palliative. Can you explain what palliative is? And was your first response to accept it?
Palliative care is basically saying we're going to support you and provide care for you, but there is no cure for your illness. So it's basically I couldn't accept it. I didn't understand. When they first said palliative care to me, I got so angry. I'm like, what are you talking about?
Mm,
Because we're here to cure my son. He's going to be treated and he will be healed.
mhm.
So I wish I didn't know some of the language. It just made me so angry. I was not any, I had a very difficult time accepting what was happening.
Yeah, and so I do wanna, clarify, so for palliative and hospice, so for palliative, there might still be a cure available for that patient, but the disease itself is either terminal or we know that it's not gonna get better. And technically, patients are supposed to be introduced to palliative care at the time of diagnosis. So even like chronic kidney disease stage 4 and stage renal disease, you might be going on dialysis and you're 40. We don't expect you to die in the next 3 years or even the next 10 years, but we know that you are in the way that your organ has failed, it's not gonna get better. So you automatically are going to have these other conditions that need additional support. And so in terms because hospice is really like, based on everything that we've seen, the chances that you could die within the next 6 months are very strong, and insurance will pay for that, right?
But
And so
thank you for that clarification. You're absolutely right about that.
yeah, we want to shout out now Dr. Anthony Young, a Dr. preferred nurse practitioner in New York, who came on and did a whole episode with us on talking about the difference between hospice and palliative. He has been in hospice and palliative for over 20 years. That was his doctoral research. That is what he's building his business on. And so that episode is linked in the description box. And so I feel as an industry, we actually fail the public because we introduce it just like it was introduced to you very late. Now, Julian's journey was rapid. That was very rapid, and for his age and the chances that he would have lung cancer, it just wasn't at the top of everybody's mind. And so, even thinking palliative, it just wasn't there. But for most of the cases, we still introduce it too late.
Yeah.
Right. And I strongly believe if we introduce it much sooner, like when you're 30 or 40, for whatever disease you might have, even a really bad asthma, COPD. There's a lot of different conditions where we know it's not going to go in the other direction, right? It's either going to slowly progress or where you are still requires a lot of management. So this is actually kind of the holistic part,
Yeah.
right? So your diarrhea, your constipation, your sleep, your insomnia, your anorexia, your poor appetite, those we can treat because if you have, say, kidney disease or MS, those specialists are treating the disease, but the disease, the medications cause side effects that alter your quality of life. And palliative care really specializes in those other areas. Not only do they specialize in those other areas, like especially chronic pain, that's a huge one. Actually,
Yes, it is.
at the time that we're recording, it's May 2026, and we're celebrating Older Adult Awareness Month this month. And we started the month on talking about chronic pain. So many diseases have chronic pain associated with them. So you don't feel diabetes, you don't feel high blood pressure, but it causes chronic pain that doesn't go away. It causes difficulty sleeping, which you can feel. Those are the things the patient talks about because those are the things they feel and those are the things they understand. The other things are important, but those are easier and they interrupt their quality of life in a major way. And so palliative, not only do they specialize in being more comfortable treating chronic pain, all providers can prescribe the same thing, but they don't feel comfortable doing it.
Right.
They don't feel as comfortable because they're managing a lot of other things. But palliative, they do feel comfortable. They do this on a daily basis. They see the outcomes in people. They know how to manage it, and they have more time. I say, even if you don't want to take what palliative has to offer, they have the time to sit with you, which when you're in a hospital, you're in a long-term care facility, and you are alone. You're alone most of the time.
Yeah.
It's nice to have someone who can sit there and talk to you about what you're going through or something else completely, but they have the time to do that. And so palliative is wonderful in that way. They can provide a lot of education for our caregivers
Yeah.
who so now my biggest thing I talk about now is to my caregivers is I talk about how me and you are standing there and I say, you know what, we're professional caregivers. We get education and training, we get sent to conference, we get support, we get paid to be here, and we get to clock out. But you, I know you introduce yourself as a wife and as a daughter, but for me, you're their advocate.
Mm-hmm.
And you're a caregiver, just like us, but you don't get anything. You don't get any courses, you don't get any money, you don't get to clock out. You have a lot of stress. You have your sleep's being interrupted, your anxiety is through the roof, your life was going on, and now this medical emergency has happened. Your life is still going on and it's needing you, but so does your loved one. And so for even our caregivers, palliative can be a huge support. And when we do start talking about hospice, they can offer you respite, which is rest. So your loved one who you love 100%, but they're agitated, they don't sleep, they keep falling out of the bed, they're wandering outside in the neighborhood, they can give you rest. So they allow them to come to a long-term care facility for 5 or 7 days while you sleep at home, get the house remodeled, go on a cruise, and then you have medical professionals taking care of them until you get back. So they can support you. We just don't know how to support you until we have the conversation. And I love to recommend them in my role to manage chronic pain because the things that I treat have chronic pain, especially nerve pain, which is very difficult to treat. And patients don't recognize that this way you describe your pain to me helps me understand the type of pain you're having and the type of medicine that will help you, because not all medicine helps the same kind of pain, especially nerve pain. And I hate to tell my patients, I'm sorry, but the pain that you're having might never go away, but we will try to do our best to get it down. And sometimes that's the only thing we can look forward to. And I love to bring palliative care in that point because they can help manage the pain a lot better than maybe primary feels comfortable.
Big
But
time.
if
Yes.
the whole team, let's say we have someone and we can all see, even the family can probably see that we're heading in a direction that's terminal, but they're not ready for the hospice conversation. I say, let's bring them in to address the pain because this is something the patient feels and the family can visibly see and understand. You bring in a team to manage the pain. Now the patient's more cooperative. They're less irritable. They're not refusing care anymore.
That's right.
And you're building a trust and you're showing that you can actually help them with the problem. Now, once you've done that for a couple of weeks, they might be more open to what they already know.
Right.
You utilize each other. That's why we're on the team.
It's so important. And, initially I was so upset. I couldn't believe that they were talking about palliative care, but they made a world of difference. You're absolutely right about that.
Yeah. And most people, they love once they do figure out who they are and what they do, they spend a lot of time telling you what a big difference they've made in the journey of them or their loved one. So we put another screenshot up here for you, when to push and ask for more answers. And you can't be afraid of that, because a lot of the reason the show exists is because of the things we don't learn. So when you go to an appointment, everyone's not created equal. So because they're not created equal and because they're working 12 hours, sitting in traffic, coming home, doing homework, cooking dinner, trying to work out, trying to get 8 hours of sleep, they might not have the time to go look up stuff. Right? They just don't have it. So you need to come in prepared so we can have a better conversation. You can get better care for you. Because at the end of the day, I'm clocking out. But you're going to go home and manage your symptoms. That's why the show exists. Because there wasn't a manual. But now there is with the podcast.
That's excellent.
And our clinicians, because I know you only have 15 minutes to sit with that person. So since you only have 15 minutes, you say, hey, go watch that episode. And next time you come back, you can take our conversation, what you learned from the show, and we can go deeper.
It's so important.
Right? Because the system's not going to change.
No.
So we have to change the way we approach it. All right.
So true.
So speaking of our caregivers, so we've talked about lung cancer non-smokers and why it gets missed. Now I want to talk about what we can do, the solutions. And I want to make space for the other half of the conversation because Destiny is still alive. Her little brother is still alive. Julian's sister is still alive. And Jean, you have spent 20 years watching what happens to children when grief goes unaddressed. let's go there. But first, let's focus on the screening, right? So another systematic review and meta-analysis published in 2025 used a computer model. So they just use the computer, put some numbers in there to look at 100,000 people. That's a large number of people.
Yes.
Now, systematic reviews and meta-analysis, they combine the results of many studies at one time. So you might not always be able to say, oh, because they drank red Kool-Aid for 7 days, this is what happened. Because they put so many things. Well, they drank Kool-Aid, they slept 8 hours, they listened to music, they smelled lavender. So we don't know exactly which one helped get to the outcome. That's the only negative about group studies like that. But we have a lot of information, and it gives us a lot of confidence when we make decisions. And this is one of our strongest forms of evidence. So what it showed is that getting a low dose CT scan or CAT scan every 2 years, starting at the age of 55, is the best value for saving lives in non-smokers. Now, another study, it was a cohort study, included women over 50 with a family history of cancer. Now your family has a history of lung cancer. Could catch many more hidden cancers. Now, if you're a woman over 50 and lung cancer runs in your family, I want you to bring this to your provider today. What do you wish you had known before Julian's diagnosis?
I don't, you know what? I wish I had known. That's a good question. We might have to put this on pause. That it was possible.
Oh, okay.
I guess that it was possible because this was not on my radar.
And the truth is, Jean, you did know it was possible, but you didn't think about it for your own children.
Not for my children.
You know, and that goes to show that nurses are patients too.
Yeah.
You can have 20 years of experience, multiple degrees, and you still are not going to think it's going to touch your family.
Yeah, it's still mind-boggling. It really, really is.
Yeah, we have to take care of each other. We're a community. So even when I come to you and I say, hey, I need help, I'm a nurse, I'm a nurse practitioner, you still got to treat me like a patient. You still got to tell me all the information, give me all the data, go through everything, because we push back. Oh, you don't have to go over that. I do that. We do that. We are the worst patients. We are, right? But this is an example that when I'm in the seat as a patient, I fall into the same category as every other patient. Okay.
And I'm gonna tell you, his provider, his oncologist, was tremendous because she, I think, a couple of times reminded me that I was the parent.
Yeah.
Because I would want to ask specific questions and talk about a research study that I read, or what about this treatment, or what about that treatment, and she just said, "You can be the mama."
Yeah.
And she was just being very polite and kind about it, but my mind was constantly spinning. I couldn't even rest at night. I had so many questions.
Yeah, I bet. And not only through the process, but even after, you're still a patient. That's why we start the show talking about what life is like at home. I'm interrupting my conversation with Jean to invite you to come back for part 2 as we continue our conversation on lung cancer and pediatric grief. In the meantime, if you have any questions, you can email us at tmi.melanin@gmail.com. If you haven't already, there's still time to subscribe, give us a thumbs up, share this information with at least one person. And then you can follow us on YouTube, LinkedIn, and all your favorite podcast apps. At the time of this recording, we release new episodes every Saturday at 8 a.m. Eastern on YouTube, LinkedIn, and at 5 a.m. on Apple, Spotify, so that our night shift friends can be the first to get something and not the last. I thank Jean for joining me, and I look forward to continuing our conversation next week, and I hope to see you there in the comments. Thank you all for watching. I'll see you all next time.